An estimated 80 million people worldwide have glaucoma, with half of that number unaware that they are affected. It is the second most common cause of blindness worldwide, however, remains the undisputed leading cause of irreversible blindness. It is also the leading cause of blindness in blacks, Hispanics, and Asians. In the UK, it is the third commonest cause of blind registration, and it occurs more commonly among the elderly people. It is nicknamed the silent thief of sight because the loss of vision usually occurs slowly over a long period of time. So what is glaucoma? The term glaucoma comes from the ancient Greek word glaucos, which is used to refer to something gloomy or a blue-gray color or appearance. The glaucomas are a group of optic neuropathy characterized by retinal ganglion cell death that result in excavation of the optic disc and visual field loss with or without an elevated intraocular pressure. The retinal ganglion cell is composed of the optic nerve head and the retinal nerve fiber layer. Generally speaking, there are a number of predisposing factors attributable to this disease. Risk factors such as elevated intraocular pressure, a cup-disc ratio asymmetry, myopia, African ancestry, positive family history of glaucoma, advanced age, etc., as well as other secondary illness which will be highlighted later. The classification of glaucoma can be extended under these three, based on etiology, pathogenic mechanism, as well as the age of onset. Let's briefly share a glimpse on each of the subclasses, starting with that of etiology. Based on etiology, could be classified to either primary or secondary. Primary glaucomas result from developmental or degenerative abnormalities that affect the channel for aqueous outflow. They are often hereditary in nature, as relative risk of one having a primary open-angle glaucoma is increased about 2 to 4-fold for individuals who have siblings with glaucoma. Some genetic mutations have also been implicated in this type of glaucoma. Secondary glaucomas, however, result from a large variety of injuries, toxic medications, systemic disorders, or ocular disease that primarily damage other ocular structures and only secondarily affect the outflow channel. These secondary factors are highlighted as follows. Onto the pathogenic mechanism. The term open angle and close angle refers to the configuration of the anterior chamber angle. This classification is made by gonioscopy. In open-angle glaucoma, the chamber angle has its normal configuration, hence aqueous humor bathes the surface of the meshwork and has access to the trabecular outflow channel. Primary open-angle glaucoma occurs in the absence of other ocular disease or congenital anomalies. In close-angle glaucoma, also called angle closure or narrow-angle glaucoma, it occurs when the angle between the iris and the cornea is too narrow, in such that the root of the iris lies against the trabecular meshwork and prevents aqueous from entering the meshwork. This blockade does lead to a rise in intraocular pressure. Angle closure may be partial or complete, intermittent or constant, as well as reversible or permanent. This type of glaucoma is more common among women. Age of onset can be classified based on childhood onset and adult onset. Adult onset can be further subclassified into congenital or infantile and secondary glaucoma in children. The secondaries here are usually associated with ocular abnormalities or systemic diseases. The clinical hallmark of glaucoma is the excavation or cupping of the optic nerve head. The pathophysiology of glaucoma is not well understood. There are several theories regarding the mechanism of damage of the optic nerve in glaucoma. We have the biomechanical theory, which hypothesizes that the retinal ganglion cell axons are particularly susceptible to mechanical damage from increase in intraocular pressure, which interferes with the exoplasmic flow as they pass through the pores at the lamina cribosa. Thus, increased intraocular pressure precipitates distinct compositional and structural change in the optic nerve head, causing nerve damage. Another theory is the vascular theory, which hypothesizes that a decreased blood supply to the retinal ganglion cell leads to nerve damage. This decrease in blood supply may be due to an increase in intraocular pressure and may also be due to vasospasm, atherosclerosis, or systemic hypotension. This is supported by the evidence that those with low blood pressure, particularly low diastolic blood pressure, are at increased risks of glaucoma. And the last theory we will be reviewing here is the primary neurodegeneration theory, which hypothesizes that a primary neurodegenerative process may be responsible for the degeneration of the optic nerve head in glaucoma. This would be consistent with the possible mechanism of normal tension glaucoma, and is supported by the evidence showing a correlation of glaucoma with Alzheimer's dementia and other causes of cognitive decline. Clinical presentation of glaucoma will range from presenting with red eye, blurred vision or loss of peripheral vision, photophobia, intense eye pain, and in severe cases, pain may be accompanied by nausea or vomiting, and the condition can be mistaken for an acute abdominal problem. Eye examination may reveal a hazy cornea, over and dilated pupils, reduced visual acuity, and ophthalmia. Other examination findings may include an increased intraocular pressure, an overall enlargement in the cup-to-disc ratio, superficial hemorrhage at the optic disc, and glaucoma flaking, which is the German word meaning glaucoma specks. These are opaque specks that may be seen in the lenses of those with glaucoma. The aim of glaucoma therapy is to facilitate the survival of retinal ganglion cells. Scientists are inconclusive on the definitive cause of glaucoma. However, many individuals with glaucoma have high intraocular pressure, and treatment that lowers the intraocular pressure tends to help to slow the disease progress. Medical therapy used to slow progress of disease are of two categories. We have those that help with increased outflow of aqueous and those that reduce production of aqueous. Of those that help to increase the outflow of aqueous, we have the prostaglandin class, the meiotic or cholinergic agents, as well as the nitric oxide class. And as for those that help with the decrease in production of aqueous humor, we have the alpha adrenergic agonists, the beta blockers, and the carbon anhydrase inhibitors. Of all, carbonic anhydrase inhibitors are the only systemically administered medications which reduce aqueous humor formation to decrease the intraocular pressure. These medications directly inhibit the carbon anhydrase activity within the ciliary body. Acetazolamide and metazolamide are the most commonly used carbonic anhydrase inhibitors. Surgical therapy is considered the mainstay of treatment for most types of glaucoma. In this day and age of advances in medicine and technology, most surgeries are done with minimal incision if need be. Surgical therapy can be classified into two. We have the laser therapy and the incisional therapy. Under the laser therapy, we have the laser trabeculoplasty. In this technique, evenly spaced argon laser burns are placed at the entire circumference of the trabecular meshwork, and approximately 3/4 of patients experience significant lowering of intraocular pressure and some lasting for several years. Another form of laser therapy is the laser iridotomy. In some cases, however, incisional surgery is still being used. For example, is the trabeculectomy, which is used for primary open-angle glaucoma, and the trabeculotomy or goniotomy for congenital glaucoma. Neuronal death and glaucoma progression may continue despite a very effective intraocular pressure reduction. Many new treatments for glaucoma attempt to prevent retinal ganglion cell death before it happens through the concept of neuroprotection. That wraps up what we have for you on glaucoma. Kindly give this video a like as it helps the video algorithm and channel. Please do remember to subscribe and click on the notification bell to get up to date with our uploads. See ya!